Hey everyone, welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Zainab Sheikh, and today we're all eyes, literally, because we're talking about glaucoma. And with me is Ayah Jamea, who's got an eye for pharmacology.
Love the pun. Hey Zainab, glaucoma might sound like just another OMA, but it's actually one of the leading causes of irreversible blindness worldwide. So yeah, this one's worth a good listen.
Absolutely. Let's break it down from the top. Before we dive into medications, let's start with what glaucoma is and what's happening inside the eye.
So imagine your eye like a water balloon with a built-in drainage system. Aqueous humor is produced by the ciliary body. It flows from behind the iris into the interior chamber and exits through the trabecular meshwork and the canal of Schlemm. If that fluid isn't drained properly, the pressure builds up, and that pressure, yeah, it slowly crushes your optic nerve.
Ouch, crushing your optic nerve sounds like something from a horror movie. So basically, even if the pressure isn't crazy high, it can still cause damage.
Exactly. That's why we always aim to lower the intraocular pressure, no matter the baseline, because the goal is to preserve vision.
Now let's zoom out a bit. What types of glaucoma are we dealing with clinically?
So there are two main types: open angle and angle closure.
What's the difference between them exactly?
Open angle is the sneaky one. It progresses slowly, silently, stealing peripheral vision. The drainage angle is open, but it just doesn't function well. And angle closure glaucoma, on the other hand, is dramatic. The angle is physically blocked, leading to a rapid rise in pressure. Think of a sudden red eye, severe pain, halos around lights, nausea. It's an ocular emergency.
Silent thief versus sudden eye assault. Got it. Let's focus first on the chronic open angle type. What's our plan to tackle open angle glaucoma?
Alright, so we have two main strategies to relieve pressure. We either reduce how much aqueous humor is produced or increase how much of it drains out. The drug classes we'll talk about are prostaglandin analogues, beta blockers, alpha-agonists, carbonic anhydrase inhibitors, cholinergics, and rho kinase inhibitors. And yes, we'll keep the names fun.
You mean fun like latanoprost, make your lashes runway ready?
Exactly that. So let's dive into prostaglandins. Latanoprost, bimatoprost, travoprost. All of these drugs ending in prost are prodrugs of PGF2 alpha. They bind to FP receptors and increase both trabecular and uvuscular outflow. The result? An impressive 25 to 33% reduction in intraocular pressure.
So these prostaglandins increase the drainage of aqueous humor and they're dosed at night, right?
Right, they can cause conjunctival hyperemia, which is fancy talk for red eyes, easier to hide while you're sleeping. But they're pretty well tolerated otherwise.
Until you wake up with Bambi lashes and suddenly your blue eyes are brown.
Actually, that's a very real thing. Increased lash length and permanent darkening of the iris are documented effects. Oh, and orbital fat atrophy, which might make the eye look sunken.
Okay, let's move on to the next class.
Beta blockers like timolol and bitoxolol work by reducing aqueous humor production. Timolol is non-selective, while bitoxolol is beta-1 selective and has fewer respiratory side effects. Their IOP lowering effect is about 20 to 25%.
Although they're effective, they can sneak out of the eye and into the bloodstream.
Exactly. Systemic absorption can cause bradycardia, hypotension, fatigue, and even bronchospasm. So we avoid them in patients with asthma, heart block, or heart failure.
So, helpful for the eye, not so much for the lungs and heart.
Our next class includes brimonidine and aproclonidine, which are alpha-2 agonists that reduce aqueous production and also increase uvuscular outflow. Brimonidine is more commonly used and it drops the IOP by around 20 to 25%.
What about side effects?
Alright, so we have allergic conjunctivitis, which is a big one. Patients can get red, itchy eyes. Rarely they experience systemic hypotension or dizziness.
This drug clearly rubs some eyes the wrong way. What about the next class?
Next, we have the carbonic anhydrase inhibitors, dorzolamide and brinzolamide. They block the enzyme carbonic anhydrase, which is involved in aqueous humor production. So less enzyme activity equals less fluid equals lower pressure.
Simple enough, but any hidden surprises?
Of course, there are sulfonamide derivatives, so be cautious in patients with sulfa allergies. They can also cause local irritation.
That's something to look out for in carbonic anhydrase inhibitors.
Then we have pilocarpine, which works by stimulating muscarinic receptors, causing the ciliary muscle contract, which opens up the trabecular meshwork.
Sounds effective, but what's the catch?
Well, pilocarpine may cause visual blurring, brow aches, and headaches due to ciliary spasm, as well as miosis, aka tiny pupils. Patients often complain of poor night vision.
I guess pilocarpine helps you see better by day, but squint harder by night.
Yeah, it can also have some sneaky systemic side effects like intestinal cramps and bronchoconstriction. Our final drug for this episode is nitarsodil. It increases trabecular outflow by relaxing the meshwork via Rho kinase inhibition. It's generally reserved for patients who need additional IOP lowering.
All right, nitarsodil is a Rho kinase inhibitor. Any side effects?
The main one is conjunctival hyperemia. It can make your eyes look like you've pulled an all-nighter.
Okay, let's do a rapid recap of the drugs used for open-angle glaucoma using some clinical cases.
Alright, a 59-year-old woman on long-term glaucoma therapy presents for follow-up. She's noticed her irises have darkened and her lashes are thicker and longer.
Classic prostaglandin analogues, don't forget that they're the first-line treatment for open-angle glaucoma.
Alright, a 72-year-old man with controlled COPD and ischemic heart disease is started on new glaucoma drops. A few days later, he presents with wheezing and lightheadedness.
This is definitely a beta blocker.
A 64-year-old woman on newly prescribed glaucoma drops reports worsening redness, itching, and discomfort in her eyes. There is no discharge. On slit lamp, you notice follicular conjunctivitis.
Allergic conjunctivitis, likely from brimonidine.
A 66-year-old man with history of sulfa allergy starts a new drop of glaucoma. Within days, he reports burning and red eyes. No systemic symptoms.
Probably a reaction to a carbonic anhydrase inhibitor like dorzolamide due to his sulfa sensitivity.
A 70-year-old night driver on glaucoma meds reports worsening nighttime vision and headaches above the eyes. His pupils are pinpoint.
Oh, this leads towards pilocarpine.
A 60-year-old man complains of having a red eye, and his eyes look like he's been having all-nighters.
That's a classic nitarsodil.
See, now you've got the hang of it.
And if one drug doesn't get us to target pressure, combining them can do the trick.
That's true.
Now let's shift to the emergency angle closure glaucoma.
So this is a dramatic sudden pain, vision loss, halos, nausea. It needs immediate treatment.
What's the go-to protocol?
You can use topical timolol, ipreclonidine, and pilocarpine, 1 drop each, spaced a minute apart. Then IV acetazolamide or mannitol. Once they're stable, the definitive treatment is laser peripheral iridotomy.
What drugs should you avoid in these patients?
Well, avoid anticholinergics and patients with narrow angles. They can precipitate acute closure. How about practice questions?
Sure. A 62-year-old woman being treated for open-angle glaucoma returns for a follow-up. She reports that her eyelashes have become noticeably longer and thicker, and her eye color has darkened over the past few months. Which medication is most likely responsible for these changes? A. Timolol, B. Latanoprost, C. Brimonidine, or D. Nitarsodil?
The answer is B. Latanoprost.
All right, Ayah, we're almost done, so let's wrap it up.
So, glaucoma is all about preserving the optic nerve by controlling intraocular pressure. We use drugs that either decrease production, like beta blockers, alpha-agonists, and CAIs, or increase outflow, like prostaglandin analogues, cholinergics, and nitarsodil. And in emergencies like angle closure glaucoma, act fast with topical and systemic agents, then send them to laser.
This was such a fun and informative episode. Thank you, Ayah.
Anytime, Zainab. Let's keep the pressure down. literally and metaphorically.
Thank you all for listening to PodBites. We'll see you next time.